So good morning. My name is Brad Wiseman. I'm the manager of hospital services here for Indiana Donor Network. My background is that I'm a registered nurse who's worked in trauma at Eskenazi in the ED, as well as in the cath lab at Methodist, IU Health Methodist here in town. For a year, I was an organ recovery coordinator with Indiana Donor Network before I accepted this current position. This morning, we're going to talk about donors who almost weren't. I'm going to be going over an actual case presentation review that we had here that posed some specifically difficult challenges to our team that we worked through, and just things that you might see us work through if we're in your hospital. So I'd like to start out by saying that although Indiana Donor Network began back in 1987, we were established as Indiana Organ Procurement Organization in 1987 and changed our name a few years back to be doing business as Indiana Donor Network. We facilitated thousands of organ donor cases over those years, but what we found is that each case usually presents unique circumstances, and no two are the same. There's usually always something that comes up that is out of the ordinary, whether it's a family dynamic or hospital difficulty or just the weather in general. But Indiana Donor Network serves as the OPO for 85 counties in the state of Indiana. We are highly regulated by several different agencies. A couple of those are the Center for Medicare and Medicaid Services, CMS, also OPTN, which is the Organ Procurement Transplant Network, and then UNOS is part of that as well. And UNOS serves to manage the database of transplant people who are on the transplant recipient list throughout the nation. Several factors affect each case, and each one of those, again, have to be addressed pretty specifically as we go through. So, as I mentioned before, some of those are family expectations around donation, some of those are hospital dynamics, some of those are donor instability, and like I said, even the Indiana weather can play a part in how we get things accomplished during a donor case. A family processing grief certainly has their own expectations about how things should happen when their loved one is passing away or has passed away. They don't understand our timelines or why things sometimes take as long as they do. It's not our first time doing this, but it's likely theirs. They have people who are traveling from out of town who want to say their goodbyes. We have to address their religious beliefs sometimes, especially when that is a concern of theirs around donation. And then, not all of our patients are brain dead, and not every family understands brain death. So being on a ventilator, sometimes families think that their loved one is not comfortable, and we have to assure them that we do everything we can to make them as comfortable as possible. Indiana Donor Network has a family services team of advocates who are there to speak with families and answer their questions, comfort them in their time of grief, and provide both hospital support and even support in the operating room when that's necessary. So some of our major donation centers see 20 or 30 donors a year. They see donors on a regular basis, unfortunately, due to the high level of trauma that they get. Even experienced nurses may find themselves taking care of a donor for the very first time. You could be at bedside for 20 years and never have the opportunity as an ICU nurse to take care of a donor. So we have to take that into consideration and not expect that someone who has been a nurse for a long time would know what they were doing each and every time. DCD cases, donation after circulatory death, require a hospital physician to be present in the OR for up to 2 hours. You can imagine what a challenge that would be to have a physician step away from his responsibilities in the hospital for 2 hours to declare a patient in the OR. And then ancillary testing, sometimes the timing of that is not very efficient for our processes, and it can be a burden to the hospital staff. So you have a lot of CTs and echoes and bronchoscopy, all kinds of testing that has to take place for someone to be a donor. And in those cases, you know, the hospital staff only has so much bandwidth, and we do our best to work with them to get those done as quickly as possible. For patients who are declared brain dead, Indiana Donor Network has a facility on the west side of Indianapolis that allows us to transfer those patients into our facility. We have a 5-bed ICU with both CT, echo, and even cath lab capabilities, so that we can take that pressure off of the hospital and perform those ancillary tests in-house, and then do the recovery in-house as well. All of our clinical protocols are developed in coordination with our Chief Medical Officer, Dr. Rowe, who you heard from earlier today. These are designed to quickly bring donors to a place of optimal organ function that gives us the best opportunity to offer those organs out and be good organs for the transplant recipients. Some of the things you may run into, though, is that pharmacy may question dosages and need reassurance that the amount of medications that we're giving to a particular patient or donor is appropriate. Brain dead donors, even though when the family makes that withdrawal decision, they usually make them a DNR, they will be changed back to a full code as long as the family is okay with that. So the best part about this piece of the process is the Indiana Donor Network has a team of organ recovery coordinators who will be on site as quickly as possible to guide those treatments and kind of assist in any questions that you might have about the clinical aspect of caring for that donor. They are very good at what they do. They all have critical care experience in the hospitals, and they go through extensive training on what it means to take care of someone who is close to death or who has become brain dead. While most of our staff and our donors are transported by ground, the surgical organ recovery teams often fly on fixed-wing aircraft in order to expedite the delivery of organs. And as you can imagine, with that, experienced or realized inclement weather causes a problem in those situations. Even thunderstorms can delay the takeoff or landing of a jet. Cold ischemic time is the time from when the organ is recovered to the time that it's transplanted. And that is the biggest thing that must be considered when we're transplanting organs, and how far we can go and what the circumstances are around that transportation. One thing that Indiana Donor Network has done to ensure that we have reliable, safe transportation is put into place TXJet, which is a subsidiary of Indiana Donor Network that is operated solely by us and provides that safe transportation for the surgeons and the organs that they have with them. So let's get into the case study. It's what you've all been waiting for. This is a 52-year-old male with a history of drug and alcohol abuse. He was found down by his son following an unwitnessed arrest. He did receive bystander CPR. A total of 60 minutes of CPR was administered prior to achieving ROSC, and that is quite a long downtime. Anybody who has that much downtime, and even with good CPR over 60 minutes, likely has an anoxic injury. When the patient finally got to the ED, the nurse recognized that he had met clinical triggers for donation and called our Vital Link Center and made the referral. The patient was in the emergency department when the referral was made, and the referral was considered timely because it was made within an hour of arriving to the hospital. And that is super important. We see our opportunities for donation decrease significantly the longer it takes for the hospital to make that referral to us. Under these circumstances, the teams at IDN must work quickly to assess for medical eligibility, determine the family dynamics, and assess the hospital culture and knowledge of donation. Like we said before, Methodist may see 20 or 30 donors a year, but this hospital hadn't seen a donor in 15 years. So after we got the initial referral, one of the staff called a nurse on the unit, and the patient was determined to have a GCS of 3 without any sedation. He had no cough, no gag. He wasn't overbreathing the vent. So, on initial look at this patient, he was presenting as brain dead. He was a registered donor, which That always puts something special in our mind, knowing that if this patient progresses to brain death, this patient is medically eligible, they will become an organ donor. And after the decision for the terminal extubation was made by the family, they left the hospital with no plan to return. That presents some special dynamics for us too, because although it allows us to move forward at a rather quick pace, we still have to communicate with that family around the process, and sometimes they're not always available to us by phone to deliver that information. One of my favorite parts about what we do is that 3 teams work together simultaneously to make this happen. Within 2 hours of the referral, a family advocate had contacted that next of kin by phone to express condolences and make them aware that their loved one had registered to be an organ donor. In this particular case, the son was on board with donation. It went very well. The conversation was not difficult at all for the family advocate. And you're wondering, why 2 hours? Well, 2 hours seems like a long time, but when we are determining medical eligibility, that information, we don't want to approach that family until we know for sure that that person is medically eligible for donation, so that they don't have to be bothered with worrying about that decision. Within 3 hours of the referral, one of our hospital services liaisons was on site to answer questions that the hospital had, who hadn't had a donor in 15 years, about the process. And their specific role is to keep those lines of communication between the hospital and our teams open, so that there's a specific point of contact that the hospital has and knows that they can go to get their questions answered. And then during this time, the organ team was working with the NP on site to aid in clinically stabilizing the patient. The patient was not stable when they got to the ED, and we were doing everything we could just to preserve the option of donation. Complication. Indiana Donor Network has EMR access at most of the hospitals in the state of Indiana. This was not one of them. So the hospital liaison, one of the first things she did was work with the hospital leadership and their IS teams to make sure that we had temporary emergency EMR access. That was a big thing for us, because if we can't access the patient's medical record, it's very difficult for us to see in real time what's going on with that patient. Other complications. The patient was hypothermic. So hypothermia can mask neurological activity. So even though he was presenting as brain dead with a GCS of 3 and no cough, no gag, not overbreathing, he wasn't warm enough for us to declare brain death. The hospital did not have the ability to perform a confirmatory EEG over the weekend, and this patient was called in on a Saturday. So we didn't know when we were going to be able to initiate brain death testing on this patient. In this situation, the hospital didn't have the ability to perform a nuclear cerebral blood flow study, which is the gold standard for determining brain death. So we're 3 days in. The hospital physician expressed concerns at this point as what might even still be able to be transplanted. The patient was requiring a high amount of oxygen on the ventilator, FiO2 of 90%. Now his MAP was good. He had a MAP of 90, but he was on 2 pressors. And the patient has not made any urine since he got to the hospital. His creatinine was 6.8. His kidneys were not working. His liver labs were elevated. He had a shocked liver from the downtime, but that was trending down, and that's what we held on to as far as whether or not this patient was going to be able to become a donor and donate his liver. Although the abdominal CT showed fatty liver disease, which is not necessarily a good sign for us either. So at this time, the patient, because they were not declared brain dead, they were being pursued as a DCD candidate, again, donation after circulatory death. In these situations, we do not take over care. We simply make suggestions about patient care to the attending physician. And in this situation, the CMO suggested that we adjust the vent settings to try to increase his ability for gas exchange. He also suggested giving fluid and addressing his electrolyte and pH issues. At some point, the donor's heart rhythm converted to atrial fibrillation, and a diltiazem drip was suggested by the CMO as well. At this point, the heart, lungs, pancreas, and kidneys were all presumed to be ruled out, and we were pursuing for liver only. Because brain death had not been declared, a physician was going to be needed to attend the process in the operating room. Anesthesia is not able to declare death on our donors for us, even though they may be present as in any other OR. The operating room staff was only on till 4 o'clock in the afternoon, and the hospital was not going to require them to come back in to facilitate an organ case after hours. Now, if brain death had been declared, if we had gotten to that point, Indiana Donor Network would have planned to transport the patient to their facility to complete the recovery process. And that's what we were actually hoping for in this situation. We thought that was the best chance of moving forward, especially with all the other complications that we were encountering. But as usually happens, there happened to be some hospital heroes. The transplant center that accepted the liver was not available for the initial set recovery time, which would have been during normal operating hours for the hospital. When the OR staff heard this, they all volunteered to stay past their shift and accommodate the recovering team's schedule. None of them were required to do that. I'm not saying that they volunteered their time. I'm just saying that they volunteered to do something they didn't have to do. And the attending physician was so excited about donation at the hospital that he also agreed to stay past his shift in order to spend 2 hours in the OR, allowing this patient to pass and become a donor. So we did recover 3 organs. We recovered the liver and both kidneys. The kidneys were placed on a pump here at our facility on the west side and offered out nationally. Although there was not interest for transplant, the kidneys were submitted for research, and research is very important in our ability to save lives as well. So we were excited about that. The liver was accepted and transplanted into a 52-year-old male who loves spending time with his family, cooking, and photography. As of today, he is doing very well. That's the exciting part of the story. Even though we only transplant 1 liver to 1 patient, that liver means everything to that person and his family. So in summary, IDN is equipped to respond quickly to assist the hospital staff and the families through these very, very difficult situations. Even though we've done thousands of cases, every case is unique, presents unique opportunities and unique challenges. Every referral you make has the potential to save and enhance lives of the people you likely will never meet. And not every donor hero saves 8 lives. Not everybody is a full donor that gives heart, lungs, kidneys, pancreas, intestine. But even saving 1 person on the transplant list is worth our effort. Thank you.